physician's orders.
Okay.
Checking the chart. I'm going to knock on the door. I'm going to gown and glove, wash my hands, and I'm going to come see the patient. Verify the patient's got a correct armband, ask him their name, date of birth, that kind of thing. Okay? And I'm going to do an assessment on this patient. And I'm going to use that as reference. So I'm going to turn off the radio, turn off the television. I'm going to regulate the temperature. Everybody feel comfortable with the temperature. Okay, good. And I'm going to assure patient privacy. I'm going to shut the door, pull a curtain, whatever it takes. So as I enter the door, as I see this patient, my assessment starts. I'm looking at the patient's work of breathing. Are they tripoding? Are they nasal flaring? Do I see any retractions? Any sort of increased work of breathing. So that's one thing I can look at as I approach the patient. Because those are all signs of respiratory distress. So that's part of my assessment. That's something I could do about right away. Do something about right away if the patient showed signs of respiratory distress. And then I can, as I approach the patient, I can identify any signs of abnormal breathing patterns. Does the patient have a normal respiratory rate of 12 to 20, or do they have long periods of apnea, biots breathing, increased malts breathing, and that sort of thing? Something I can assess by just looking at the patient. And then breathing pattern. So the patient does not have any abnormal breathing patterns. He's got a normal respiratory rate of 16. I can do that by just placing my hand on the chest and feeling chest rise. Sometimes you can look at the patient breathe and count chest rise that way. But sometimes if they have a really thick gown on or a gown on, it's hard to assess. You guys learned that as you palpate their pulse, you can look at chest rise. So then I'm going to have the patient sit up for me and place her back to me and slightly bend over. And then I'm going to assess their back and for any, make sure that their back is fairly straight. So if there's any kyphosis or scoliosis, I'm going to take my finger and kind of run down the backbone, all the way down. Because if the patient did have a significant curvature in the spine, it's going to ultimately alter their breathing, alter their lung function. Again, I could go on this side, run my hand all the way down, and make sure they don't have a curvature of the spine. Make sure it's properly curved as it goes in and out. Okay, so I've assessed that. The patient does not have kyphosis or scoliosis. They've got a normal backbone. And then now I'm going to check for their AP diameter. So as the patient sits up, I can have them lift their arm, and I'm going to check basically their diameter from their chest wall, anterior posterior to diameter. And it should be half the size of the width of their chest. Okay, so have the patient raise their arm, and I can assess their AP diameter. In this case, it looks fairly normal. That this patient does not have an increased AP diameter. You typically see that with your people with obstructive diseases, bad COPD. I often see it, and not only does it cause an increased AP diameter, but it also spreads out. Your rib cage, and when it does, it causes your this bone right here to poke out a little bit. So that's something to assess. What's that? The manubrium? Yeah. I always call it the sternum, but if that's a fancy
That's a professional jargon.
so that's the tip of it. But typically your sternum will be poke out a little bit because your rib cage turns a little bit when you get hyperinflation of the chest. Something to look for, AP diameter. Again, you're going to see with your COPD patients, your patients with severe obstructive disease. Clubbing of the digits, I'll ask to see their hand. You're going to show me his hand. I'll quickly assess for any clubbing of the digits. You guys have seen pictures of that. It's when the last digit of your finger is very pronounced, it's very enlarged, and that comes with severe chronic hypoxemia. And then I'm going to do that capillary refill. Take his hand, pinch the fingernail bed, not too hard, and then I'm going to blanch it, and it's going to fill up hopefully within 3 seconds. That's a good capillary refill time. Then I'm going to go to the chest. I'm going to visualize the chest. I'm going to make sure that the tracheal position is in correct position. I want to make sure it's midline, right? So I can take my finger and on the outside of the trachea, kind of work my way down and make sure it's midline on both sides. I've also seen methods where people take a V and kind of go down like such and make sure it's midline. Because if this patient had a pneumothorax or severe atelectasis, it can cause that tracheal shift. So you don't want the trachea to be, like such. You want it to be midline. Again, that's also something you'll see on a chest X-ray.
Do you use or can you use the clavicle as like a guideline to make sure that this midline goes right through like the middle of where the
Yeah, you can. As long the clavicles sometimes can be very low, and sometimes on a severely obese patient, you're not going to be able to see their clavicles. Since we're on the subject of, but you don't always see people's clavicles, but it's a good landmark to use if you have them. But make sure the trachea is midline. Areas of tenderness, that's easy to do. I can say, let me know if this hurts. If the patient had, say, a broken bone or something of that nature, this is probably going to be a painful stimuli to them. That's one way to check for areas of tenderness. Chest wall excursion. So this is an important one. So what I'm checking for is making sure we have equal bilateral movement of the chest wall. So what I do, and you can have the patient, face you when you do this. I'm going to take my hands like such and place on the patient, and I'll have them take a deep breath, and I should get equal bilateral movement with my hands, right? I should get equal movement with my hands. So that's just telling me that each lung is working independently, but they are equal. Again, I'm going to go down here, take a deep breath. Very good. I'm going to go on back. Take a deep breath. Take a deep breath. Have the patient lean over, take a deep breath. All right, so that's checking for chest wall excursion. Again, simply just making sure that each lung is, although they do work independently of each other, I want to make sure that they have equal excursion.
James, you're looking for 4 zones? Two.
Yeah, you can look for 4 zones.
Twist, isn't that gonna make me off?
No, I'm not twisting you. I'm not twisting you. I'm basically just having like sit in bed like that. I'll be on the other side. I'm not necessarily twisting.
I thought you said having been over.
Well, you can have them bend over slightly, like such. You can also do that when checking their spinal cord. And then I've done my chest wall excursion. Again, if they had a pneumothorax, or say they had a paralyzed diaphragm, I wouldn't get that excursion on that side. I would with the other side, right? If this patient had, say, a paralyzed right-handed diaphragm, I wouldn't get that excursion. So it would be more like this, right? That makes sense? Mm-hmm. Okay. So that's checking for chest wall excursion. Next would be chest wall excursion, excess tactile frenemies. So this is something tactile, is something I can feel, right? So we've discussed breath sounds in the past. We've discussed rhonchi and coarse crackles. These are things you can you may be able to feel as well. So I'm going to place my palms and my hands on the patient's chest and have them take a deep breath. if they had something like a rhonchi, I could feel that. I could tactically feel that with the palms of my hands. And as the patient takes a deep breath, I could feel basically their lung movement in my hand. Again, take a deep breath. All right, I'm gonna go to the back. Take a deep breath. Take a deep breath. All right, so if they had some consolidation, say in the left lower lobe, tactile firmness, I could possibly feel that with the palms of my hand. Just those coarse crackles and that decreased air movement in that lobe of the lung. Next is vocal fremitus. So this is when you can get the patient to say E as you place a stethoscope on them. And areas of higher consolidation, that E will sound more like an A. So again, I'm gonna, rather than have the patient take a deep breath every time I place this on the chest, I'm gonna ask them to say E, okay? So I'm gonna start up here in the apex. E, 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 A. So I know down here there's increased consolidation because of that blunted E sound. E, E, okay? Do the same thing on the back. E, 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 A. The same side. E. So I know I have maybe some consolidation in my lower lobe because of the vocal fremitus change from an E to an A. That's a good sign of increased consolidation. And then percussion. Percussion, you saw in the video the guy uses his one finger, and we're basically, you want a resonant sound over the lungs. Imagine tapping on a hollow drum. Now you're going to get some sort of percussion over lung tissue. Now, if I were say over rib cage or something like that, I may get more of a thud. Or if this guy had like very if he was a weightlifter and he had like very muscly pecs, you get more of a thud. So you kind of want to avoid those. Now, if I have a sound here that's less resonant, more of a dull sound, that's a good indication of fluid in that space or some sort of consolidation. So when it goes from resonant to a lot less resonant, I'm losing some of that resonance. It's probably because of the fluid buildup there. So there's a good chance that there's some sort of consolidation there or fluid buildup. And then it's going to be very hyper resonance when there's air trapping involved, like COPD, emphysema, or a severe pneumothorax, and there's nothing but air there. So those are things you want to account for. And then there's the diaphragmatic excursion, which we just saw the video of. You just have you're behind the patient. You want to have them set up like such, and then in the video they start at the apex of the lung, and you and tap until you get to that thud. Okay, there's my diaphragm. Have the patient take a deep breath, and then in doing so, you're going to assess the diaphragmatic excursion. And in normal individuals, it should be around 3 to 5 centimeters. So once you find the base of that, you have them exhale normally, and then you work your way up, and until you get resonance again. When you hit resonance again, you're in lung tissue. So that distance should roughly be about 3 to 5 centimeters of a diaphragmatic excursion. That's gonna people that are going to be affected with that are your patients that are your CNS patients, your patients with like ALS patients that's going to lose that diaphragmatic function. It could be a patient that's a quadriplegic or something like that that does not have that diaphragmatic excursion. And those are the patients that aren't going to have a good effective cough either. And I think that's last on our list, right? Ask the patient to take a deep breath and cough. One thing I want to do is not only assess what comes out of their cough, but assess if they can cough or not. Can they develop a strong cough? If they can't, we may have to get some other devices to help them cough. But if they do cough something up, I want to check the consistency, the color, the thickness, the odor, and the taste of that of what they cough up. Because if it's very, very colorful, there's a good chance it could be an infection. If there's a lot of it, we may need to provide some sort of therapy for that. So, and then when we're done with the assessment, of course, we chart everything. We take our gloves off, we clean up, and we get out of the room. Any questions?
Oh, yeah, I got a question.
Yeah.
When you say we can start bringing in like a sheet of paper or something at our conferences?
Okay, that's cool with me.
Your conferences?
Yeah. You can bring in a scribe if you want. Yeah, piece of paper is fine. You can document what you find right away. So, yeah. Anything else? So we're going to start incorporating some of our. So as we go down further down the road, we're going to be part of our assessment skills are improving, right? Just 3 or 4 weeks ago, we were just getting a pulse ox on the patient. Now we're basically doing a full body assessment. So as we see our patients now, we're going to be able to know a lot more about them within the first few minutes. And again, part of this assessment is we're going to add pulse oximetry to it. We're going to ultimately add ECGs to it. We're going to see what their heart rhythm looks like, and we're going to add all sorts of things to it. So this is where we are right now. So. All right, I'm going to give you guys some time to practice this, okay?